All right, today we are going to build step by step the mental algorithm that every safe, effective nurse uses on every single shift. Think of this as your whiteboard guide to making great clinical judgments. Let's jump right in.
So picture this, 5 patients, one of you, and absolutely zero room for error. This isn't some riddle, right? This is the reality of a nursing shift. You've got alarms going off, families with questions, and it feels like everyone needs you at the exact same time. The real question isn't if you can handle it, it's how you handle it perfectly. How do you decide who to see first, what to do next, and then how do you even know if what you did actually worked?
Well, the answer, the secret sauce, is that it's not magic. It's a process. It's a repeatable, logical, and most importantly, safe algorithm that you run in your head. It's like a mental flowchart that guides every decision you make, and today we're going to draw it out together. Okay, let's start building this thing. The absolute foundation, the bedrock of safe nursing care is step 1, prioritization. Before you can do a single thing, you have to figure out who needs your attention right now.
I want you to think about prioritization like a big funnel. At the very top, you've got your high priority patients. We're talking immediate threats to life. These are your non-negotiables. Then in the middle, you have intermediate needs, things like a risk for infection. Super important for sure, but maybe not life-threatening in the next 60 seconds. And then at the bottom, you have low priority needs, things that focus on long-term well-being.
So how do you sort your patients into that funnel? You use these 2 critical filters. The first and the most important one is the ABCs, airway, breathing, and circulation. An airway problem will always win, no matter what. After that, we can apply Maslow's hierarchy. You know this one. Basic physiological needs, like getting enough oxygen, always come before anything else.
All right, let's put it to the test. You've got 4 patients here, and they all have real, valid needs. But who do you literally run to first? The one with the infection risk? The person in severe pain? The patient with an O2 sat of 88%? Or the one who's anxious about going home? Go ahead, apply those filters. The correct answer every single time is C, the patient with an O2 sat of 88%. Why? Because this is a direct threat to their breathing and circulation. It's the B and C of your ABCs. Their brain needs oxygen right now. Look, severe pain is a high priority, but it's not going to kill them in the next 5 minutes. Infection risk is intermediate, anxiety is lower. The ABCs always win.
Okay, you've prioritized, you're in the room with your patient. Now what? Well, step 2 of our algorithm is all about defining success. You gotta know what you're aiming for, because if you don't know where you're going, how will you ever know if you got there?
This quote really gets to the heart of it. Vague goals just lead to guesswork. If you can't actually measure progress, you're basically just crossing your fingers and hoping for the best. We need cold, hard, observable proof that what we're doing is actually working.
Okay, here is a super common mistake we need to fix right now. An intervention is what you, the nurse, do. An outcome is what the patient achieves. So writing ambulate patient as a goal, that's wrong. That's your task. The goal, the outcome, is the patient will ambulate. It's a small change in words, but it's a huge shift in focus from you to them.
So, to make sure our outcomes are rock solid, we use the SMART framework. It's got to be specific, one goal at a time, please. It has to be measurable. Use actual numbers like O2 sat of 92%, not vague words like breathing improves. It has to be attainable. The patient has to be on board with it. Realistic. Don't write a walking goal for someone who is paralyzed. And finally, it has to be timed. Every goal needs a deadline so you know when to check back in and reevaluate.
Time for another check off. Let's go back to our patient with impaired gas exchange. Which one of these is a perfect SMART outcome? A, B, C, or D? The answer is C. Let's talk about why. A is what the nurse does, not a patient outcome. B is totally vague. What does feel better even mean? And D is actually 2 goals smashed into one, which violates our specific rule. C is the only one that checks all the boxes: specific, measurable, attainable, realistic, and timed. That's a perfect goal. Okay, we figured out our priority patient, we've set a beautiful SMART goal. Now it is time for step 3, action. This is where we choose our interventions. This is the how. How are we going to get the patient to that outcome? Your actions basically fall into 3 buckets, and it all comes down to authority. There are nurse-initiated things you can do totally on your own, like repositioning a patient or doing some teaching. Then there are provider-initiated actions that need an order, like giving meds. And finally, there are collaborative actions, where you're working as part of a team, like with a physical therapist.
Now hold on, before we go any further, we have to insert a huge, flashing, red lights step right in the middle of our action phase. This is probably the most important safety checkpoint in the entire algorithm, avoiding the blind obedience trap.
I need you to let this sink in. Just because an order is written down does not mean you just do it, no questions asked. Your nursing license, your critical judgment, you are the final safety net for that patient. If you give a med based on a wrong order, you are just as legally responsible for that mistake as the doctor who wrote it.
So what do? Here's the protocol. Simple as that. 1, you get the order. 2, you stop and you critically assess it. Does this make sense for my patient? If it seems unsafe or just off, step 3, you must clarify it with the provider. You advocate for your patient. And only after it's been clarified and you know it's safe, do you move to step 4 and implement it.
Let's apply this. An order comes in. Strict bed rest. Do not turn patient. But you know this puts them at a huge risk for a pressure ulcer. So what do? A, follow the order exactly. B, just turn them anyway and hope nobody notices. C, write a note that says doctor refused turning. Or D, consult the provider to clarify the order and explain the risk. The only safe, legal, and professional action is D. You can't just follow an order that you know could cause harm, but you also can't just ignore it. There might be a reason for it. You have to clarify. Okay, we've acted, and we've acted safely. Now for the final step in our algorithm, closing the loop. Patient safety is most at risk during handoffs and transitions, so our communication has to be absolutely flawless. This timeline shows a really critical point that a lot of people miss. Discharge planning does not start on the day the patient is leaving. It begins the second they are admitted. From day 1, you have to be thinking about their home situation, their support system, and what they're going to need to be safe after they leave. So to make sure our communication is standardized and safe, especially during a handoff or when you're calling a provider, we use ISBA. It's just a simple framework to make sure no vital information gets dropped. You identify yourself, state the situation, give some quick background, offer your assessment, and then make a clear recommendation. It's clean, it's safe, and it works. Wow, we have covered a lot of ground. We've built this whole algorithm piece by piece. Now, let's put it all together into one simple exam-ready blueprint. And here it is, the entire process on one slide. It's a loop. First, you prioritize using your ABCs. Second, you set a measurable SMART goal. Third, you act, but you always run it through that critical safety checkpoint. And fourth, you coordinate care and communicate clearly using a tool like ISBAR. This is the loop you run for every single patient all shift long. So let's end here, because this isn't just theory, right? This is your actual practice. The next time you walk onto the floor for a shift or for your next clinical, what's the very first safety check you're going to make? This algorithm is yours now. Use it to stay safe and, more importantly, to keep your patients safe.